Welcome to Health Focus, where we focus on your health. This has been a difficult time for all of us in the community as we've been struggling with the pandemic, and we're very fortunate to have back a great friend of Health Focus who's joined us before, the Public Health Officer for Solano County, Dr. Bella Matias. Thank you so much for joining us, Dr. Matias.
Thank you very much, Dr. Scott. I'm very happy to be here.
Maybe we can start by just recapping some of the numbers in terms of this pandemic. Can you bring us up to date, Dr. Matias, on how many people have been infected, how many people may have died from this on a global basis and on a more local basis?
Well, on a global basis, as you know, we're talking about millions of individuals and we're talking about hundreds of thousands of fatalities. This is definitely a very serious pandemic internationally. In the United States, we're closing in on 100,000 deaths, which is a very large number. And it's in the range of what has been predicted by some people, but it's higher than what a lot of people were predicting, and certainly higher than what any of us were hoping we would be able to sustain. Here locally in the Bay Area and in Solano County in particular, the outbreak has been under relatively better control for a number of weeks now. In our own county, we have had 18 fatalities and about 435, 440 cases. And our numbers have been relatively steady for a period of time. We have had a large cluster at a nursing home, and that accounts for about a third of our cases and the majority of our fatalities. And if we take that out, we've actually been doing very well relative to the Bay Area as a whole. But you know, that's just relative because we're still talking about a lot of people dying and a lot of people becoming sick.
I believe the nursing home has been covered a lot in the news locally. It's, I believe, the Windsor Nursing Home in Vallejo. Is that correct?
Yes, that is correct. And as I say, it's accounted for a third of our cases and the very vast majority of our fatalities.
One of the things I always wonder about as a physician is how deaths come to be attributed to COVID-19. For example, if you have someone who's susceptible to dying by virtue of being old, being frail, perhaps having Alzheimer's disease, are we relying on the death certificate to determine the cause of death? How do we figure that out?
In this particular situation where we are in the pandemic, we have made the decision that anyone who has COVID-19 disease at the time of death died from COVID-19. And that's really just so that we can have consistency in how we measure. The truth is, as you've noted, the majority of the fatalities at that nursing home were in people who were on hospice care. That meant that they were expected to die relatively quickly because of significant underlying health issues. Did the fact that they have COVID tip them over and make them die a little bit faster? Was it just coincidental and they were going to die then anyway? Is impossible to know. At some point in the future, there will be different criteria. There will need to be evidence that COVID caused the death in order to attribute it. But right now, we're really forced to just count it if a person is positive when they die.
I guess one of the implications of this, of course, is the degree to which we would recommend confining populations or at least discouraging people from going out. For example, the Wall Street Journal reported today, on the day we're filming, that in the entire country, there have only been 15 fatalities of people under the age of 15 and 200 cases. The implication being that the number of cases in very young people and pediatric populations is very small. I suspect there are more cases than that because we've seen case reports of inflammatory disorders in kids that are in my own field of rheumatology. But do you think this is primarily a disease that represents a major health threat to the elderly?
I do. I believe that the elderly, especially the frail elderly, people with significant underlying health issues, are the ones at greatest risk of being hospitalized and dying. And I think the data bear that out. The elderly and people with significant underlying health issues represent the vast majority of the people who have died. Unfortunately, there are going to be deaths of all types of folks in all age groups, including otherwise healthy people. That's just the nature of any disease. But there is a clear correlation with being older and with having underlying health conditions. And I think that there's also probably going to be a correlation between symptomatic illness and age. And so I think what we'll find is that younger people, who represent about 3% of the reported cases in total, have a higher proportion of asymptomatic, and so they're being under-identified, but at the same time, their outcomes are nowhere near as bad, and that undercounting isn't as important from the standpoint of understanding what's going on. the primary concern with young people is that they can bring the disease home to elderly people. And so we don't want to ignore the fact that they may be vectors of transmission to high-risk people, even though they themselves may be relatively spared from the worst outcomes of the disease.
That's an excellent point. And I should correct that. I think in that Wall Street Journal article, the number 200 may have referred to hospitalizations under age 15, because clearly there are going to be more people that are seropositive at all ages than just a few hundred. But let us turn to the issue of flattening the curve. Obviously, when the governor first issued his shelter-in-place order, the concern was not overwhelming medical locations by flattening the curve and diminishing the number of cases. Do you think we were successful in that respect in flattening the curve, and how does the future look in that respect?
I think that there are a lot of ways to answer that question. The first is that with the exception of a few places like New York City, which clearly stands out in stark contrast, that the curve has been sustainably flat for most of the country. And it certainly has been throughout California. And so whether the stay-at-home orders or played a role in that, or whether it was the fortune of our demographics, it's very difficult to know. But we can be grateful that we have had a flatter curve than might have been the case otherwise. But unfortunately, it doesn't work equally well everywhere. New York City is so densely populated that there, the transmission, even with these types of protections, was far, far greater. As for what the future holds, if in fact we are at a place where we don't need to worry about our hospitals experiencing a surge, we have more freedom in terms of the degree to which we can relax stay-at-home orders and allow businesses and activities to resume. But I do believe that our future will find us having to address this disease often. I think that this disease will probably establish itself as one of the many that circulate every winter in our communities, and we will have to address it in the upcoming flu season and potentially every year thereafter. But our ability to do so will improve with time. We'll have vaccines, for example, which will help us to address it in the future. We'll have more herd immunity, so fewer people will be vulnerable to being exposed. So like any other pandemic, over time, its impact will diminish. But I think that we will be recognizing it as a disease that stays with us.
One of the issues that has been brought up by some people is the concept of moving the goalposts. In other words, that originally the desire was to flatten the curve, and that over time, some in positions of authority have suggested, no, we must wait until we have a vaccine. Now, I know that the North Bay counties, including Solano, our county, and Napa as well, and Sonoma, have really tried to open up a little bit more quickly. But as I'm sure you're aware, as a public official, there have been protests, there have been people who have expressed profound concern about the slow pace at which we're moving towards opening businesses, restaurants, and schools, for example. Could you comment on that? Do you think that we may have been overly aggressive as a society in terms of pursuing this close down process, or do you think it's been pursued in a judicious and appropriate manner?
I think it's important to remember that people's cultures and philosophies vary. Just in our own county, our North County culture is very different from our South County culture. I get just as many complaints from parts of the county that we're moving too fast and others that we're moving too slowly. And I think that variability exists everywhere. I also think that there isn't consensus on the notion that we need to maintain the stay-at-home orders until there is a vaccine. It comes back to our philosophy. What was our goal? Because at the same time that we reduce the number of cases, we benefit from reduced death in the high-risk individuals. That's a good thing. But we slow down the pace of herd immunity in our community, which means people stay vulnerable for longer. There's a trade-off there, and it's not at all clear what the best path is. All I can offer is philosophies differ and people's desires differ as a consequence. And so I don't know that there is a simple answer to what is the best path. And I think that it's at this point fruitless to second guess how we got here. We are here, and what we have to do is move forward in the most intelligent way possible. There will be people who will argue that the stay-at-home order did nothing to flatten the curve, that in fact it had such a minimal impact on our populations that the transmission occurred as it was going to occur anyway, and there'll be others that argue that it was the best thing we could have done. And I believe that it'll be impossible to prove either of those philosophies. So rather than focus backwards, I think we know where we are. We know what our desire is going forward. We need to keep our eyes on the goal of allowing as much resumption of normalcy as possible while protecting against the harms that we are really trying to avoid with this pandemic.
I think you frame the question very well, that it's a balance between individual freedom and safety, and different people based on their philosophies and backgrounds have different degrees of risk tolerance. As you face these issues, do you coordinate with state and federal authorities, and have they been helpful and forthcoming to you as one of our local county officials?
They've been doing the best they can. Yeah, this has been an extremely difficult time for everyone, because leaders have to be leaders, and there are different goals at the national level than at the state level and at the local level. So I think that it is easy for me to put myself in their shoes, and with that, believe that they have done the best they can, and that they have been transparent, and that they have been conscientiously trying to do what's right for people. And even with that approach, you're going to get a lot of differences of opinion and a lot of differences of approach. So I don't fault anyone in terms of their effort, in terms of how they've worked with one another. And I think that it's too complicated a situation to pretend that we ever know the right answer. We go after the best answer that we can make sense of, and that's what we try to pursue. So yes, I think we've been working well together.
I should say, by way of a parenthetical comment, that you've been really remarkable in terms of your availability, not just to our show, but to the community. And I really appreciate the fact that you've given so many talks and been interviewed so many times by the Daily Republic, local news organizations, to try to tell us what your thoughts are. And I think you are to be commended on that. And if I could, I'd like to address this issue of culture. Sweden, for example, has been described as a culture that has a high level of social trust. And some people think twice as high as what we have in the United States, and a high level of respect for autonomy, in which they tend to favor recommendations rather than mandates. And as I'm sure you're aware, Sweden has actually limited the extent of their own lockdown. They've encouraged elderly people to stay at home, but they've allowed primary schools to remain open. And my question to you is, what do you think about this as a way of fostering what is known as herd immunity? Perhaps you could explain herd immunity. And shouldn't we consider emulating the Swedes, and at the very least going back to more sports activities for our young people and opening schools as quickly as possible?
So let me begin by defining herd immunity. It's this idea that if enough people are immune, that the people who are vulnerable are fewer and farther apart, so the disease doesn't spread as easily. And so the goal is to have enough people immune and scattered among ourselves, so that those of us who remain vulnerable are not as likely to be exposed and get sick. And herd immunity is an important concept it's an important goal to try to achieve in any disease that spreads through our communities from person to person, because it is a way of protecting us from bad disease outcomes. And the most common way we achieve herd immunity in modern America is through vaccination, which is why we keep talking about having a vaccine for this disease. That is a way of making people immune in large numbers. The other way is through disease. Sweden has taken the approach that the vaccine is too far off in the future, that they are by and large a very healthy people, that for the most part they expect to sustain less bad outcomes, and that they would like to get to a place of herd immunity more quickly. That is a very valid philosophy, and it's scientifically sound, provided that you do what they have done, which is protect the vulnerable. And there are many people in our own country that have espoused that that's how we should have gone, that rather than protecting everybody and then leaving everybody vulnerable, we would have done better to make sure that the vulnerable populations, the ones we're most worried about, are the ones we protect, and everybody else goes and gets exposed, and then there's less of it to go around. I don't know that we can emulate Sweden in America, because we are different culturally. There is a lot more, I think, risk of people in that setting here not following the expectations of properly protecting the vulnerable, and so we may not be as successful at it. There's also potentially a different expectation of risk. I do believe Americans may operate with a lower tolerance for risk than might be the case in a country like Sweden, and that clearly influences the willingness to take that type of a bold approach.
I think you've stated that in a very articulate manner, Dr. Matthias, and I can't disagree with anything you've said, except to point out that To some extent, when our economy really nosedives and when we find ourselves in a situation in which people are remaining at home, our health also suffers, does it not, in terms of things such as depression, lack of primary care follow-up, potential for alcoholism and drug abuse. And I have to confess that as I've thought about this and written a few articles about this for our local paper, I've come to the conclusion that perhaps the cure is worse than the disease when it comes to really locking down our country, if one takes the long view and considers these other morbidities. I realize there's no simple answer to that, but do you have any thoughts about these other concerns? And I believe other physicians have also raised these concerns.
I think that question is easy to answer when you take an epidemiologic approach, when all you care about are raw numbers and not the people involved in the numbers. I believe that there will be efforts made to identify the increase in death that has occurred because of what we did compared to the potential reduction in death from the pandemic by what we did. And I'm not sure that we're going to end up with the outcome that we were hoping for. However, the average person perceives the risk of diseases they know and understand very differently from the risk of a disease they don't understand, that they therefore fear. And I think we also need to respect the fact that a lot of folks had a level of concern, have a level of concern about this virus that is greatly exceeding their level of concern for diabetes, cancer, heart disease, suicide, which are the causes of death that will increase because of the impacts on the economy. I do believe that in retrospect, we will be able to identify that alternate paths may have been wiser to take. But I think more importantly, we should be asking ourselves, can we modify the path we're on now to minimize the economic harm and these other unintended consequences while still protecting our community? And it's a difficult question because fear causes stress, stress causes disease. And so how do we measure all the different components that cause bad outcomes and then compare them to one another?
Yes, and also economic privation causes disease. That's been shown in terms of survival for example, cancer and other illnesses. But you framed the question very well, and I'm sure we'll be studying this for many years to come. Let's turn towards the subject of testing. I wonder as a physician exactly what we're trying to accomplish with testing. Typically in medicine, we only order a test if it will change our treatment of an individual patient, for example. What testing do you recommend in the population, and what is the purpose really, when you get down to it, of testing large numbers of people?
I think that it is a very complicated subject, largely because we have taken so much for granted the notion that we need a lot of testing that the very concept of challenging it makes it hard for people to really explore what we mean by challenging it. Because who's not talking about we need more tests, more tests? I agree with you that a test only has value if it affects the outcome. And I believe that testing people who are hospitalized makes a lot of sense if it changes their course of treatment. I don't believe that testing necessarily matters for an individual who is going to be isolated for the right period of time anyway, with or without a test result, because they're going to be isolated. But it does provide knowledge for them. And one of the things I think we have to acknowledge is that the simple value of that knowledge is a significant stress reducer. And so, I think people believe that they are entitled to know, people want to know. And so testing at the level where people who want to be tested can be tested is probably sort of the best balance point. That way they can get the results that they want, whether or not it makes a difference in the outcome, as long as it doesn't come at the price of testing those people we need to test. So, and I don't believe that that's at risk anymore. I believe we have more than enough testing available that where it's beneficial, we can do it, and have enough volume of testing available for those who want to be tested with minimum harm in the process of doing so.
Does the test involve an antibody test, or does it involve actually checking for viral activity that represents a risk to others?
Right now, we're mostly testing just for the virus. The antibody tests are slowly coming along. The problem with the antibody tests is they are many in number, but very few are well understood and are trustworthy. So there are a lot of antibody tests out there that are giving us a lot of false positives and false negatives, and that information is harmful. It's not helpful. So I think people need to be patient for a good antibody test to come along. And then at that point, I think there will be value in some settings to know if you are protected by antibody or not. But we have to remember an antibody is not perfect. If you are exposed to an overwhelming dose of the virus, antibody or no, you may not be protected from disease. So you have to be careful not to be cavalier in your exposures just because you know your antibody status. So I think that there too, more people will want it than probably need it, but to the extent that it'll be available, that knowing that information is not bad, as long as you don't use it as an excuse to abandon social distancing, which has value that goes way beyond protection against COVID-19.
Another area of concern, I think, is the possible stigmatization of people who have positive antibodies once the tests become more widely accepted. People have talked about getting sort of passports that document that you've been exposed and so forth. And some commentators in the medical community and elsewhere have expressed concern about that. As you know, most of us have antibodies to a lot of viruses, including Epstein-Barr virus, for example, but we're not harboring the virus. So I think it's a bit of a sticky wicket to contemplate, frankly.
I can't disagree. I think that stigmatization is a risk with a lot of this information. I would actually, though, offer that if you are someone who is immune, that's more of a badge of honor than a badge of shame, because you are free to move about more easily. So I'm not really sure that everybody would agree that it's a negative thing to have a positive serologic result versus a positive thing. All I know is that it's going to happen whether or not we recommend it, and so better to be prepared for how to deal with the results.
In fact, later this month, I'm going to be on the inpatient service at UC Davis for rheumatology, and I'll have to go through some kind of screening. But the idea of having to present your antibody papers to people is something I find chilling, I must just share on a personal basis.
I don't disagree, and I think it depends on the context, because remember, as a physician, you also needed to show immunity to a number of other diseases when you were entering into your residency program, and that's to protect our patients. And we use it in order to get vaccinated, not in order to be punished. But MMR and a number of other vaccines are typically expected of us, hepatitis B, with the goal that we would then be vaccinated if we're not adequately immune. And so I think that it's how the information is used that makes the difference in terms of the knowledge.
Yes, and I guess we'd have to add tuberculosis screening to that. So those are good points. Our time is growing short, but Dr. Matthias, what do you see on the horizon in terms of developing a vaccine, particularly in terms of the time?
I think that we typically would expect a vaccine to take about 18 months, but with the current climate and demand for the vaccine, I think what will happen is that phase 2 and phase 3 trials will be run concurrently and not sequentially, and that could clip off a good 6 to 10 months, thereabouts. So it's not impossible, if the right vaccine candidate is being tested, to have a vaccine available by the next cold and flu season. It's not impossible. It's improbable, but not impossible.
Do you have any thoughts on treatment modalities, particularly in terms of, for example, hydroxychloroquine, azithromycin, or some of the biologic agents? We don't have the double-blind trials. Some people are using some medications off-label. Any thoughts on this?
I think that that's a really tricky road to be on. Remdesivir has been shown to have value in certain circumstances for patients who are very, very ill, and we need to await the clinical trials before we start treating people in large numbers with any of these types of treatments. I think hydrochloroquine has been shown to be potentially very harmful. It's a medication that is well known to us. We know its side effects. We know its usefulness. No clear benefit to this disease at all. And I think the off-label use of medications when a person is near death makes sense, because you're trying to save a life. You'll do anything you can. But that's very different from routinely treating people who are otherwise potentially going to remain stable with something that might make their course of illness worse.
With respect to hydroxychloroquine, we use that a lot in rheumatology, and I've always thought it has a very positive safety profile. It has risks such as retinopathy and cardiac toxicity, but as drugs go, it's a relatively benign one. In terms of evidence of efficacy, I agree with you. We don't have really good data. I think there are some reasons to think it might be helpful, but I guess we'll have to wait and see. So we'll get back in touch with you on that in the future. May I ask you also about future pandemics? Do you see anything else on the horizon?
I think that I've been at this for 30 plus years, and there hasn't been a year when we haven't had a new zoonotic disease identified that harms humans. And in the course of my career, I've been through half a dozen pandemics. This one has been reacted to very differently than the other ones that I have been through. And I don't know if this is a harbinger of a similar reaction for future pandemics or if we're going to react in a different way with future pandemics. But it's almost a certainty that we will continue to experience pandemics as a people. And they won't all be equally dangerous. They won't all be equally easily transmitted or equally frightening. But pandemics occur with regularity. And I think that we simply need to be prepared for that.
We're down to our last minute or so, but in a few seconds, do you have any closing advice to the community as we begin to finish up our interview?
I think that one of the things we can take away from what we've experienced is the powerful value of social distancing in trying to prevent disease transmission for respiratory diseases in particular, but also for other types of diseases, foodborne, et cetera. And I'm hopeful that people will heed our asks of them every season to employ social distancing to protect themselves from influenza and other diseases, as well as COVID-19. So I think a takeaway is that we can do these sorts of rational things in a rational way and benefit ourselves and our families from transmission.
Dr. Matias, on behalf of all of us here at Health Focus, I'd like to thank you for your availability to us and for the excellent public service you've offered to the community throughout this epidemic. And I hope you'll come back and visit us again.
Very happy to. Thank you very much.
Remember, here at Health Focus, we focus on your health. This has been a difficult time with this ongoing pandemic, but together we're going to pull through it. Thank you so much for joining us. Thanks to all the first responders in the community. Thanks to all the people who provide all the services to the members of our community, not just police, firefighters, and health professionals, but also the people who try to teach our children during this difficult time, provide us with food, provide us with all the essential services and goods we need. We really appreciate the effort of everyone in the community here at Health Focus, and we look forward to seeing you again, hopefully when this pandemic is in our rear view mirror. Take care.